Hello, everyone. Just give it about 30 more seconds for people to join, and then we will get started.
I turned off the waiting room now, so everyone will be able to join directly.
Thank you, Debbie.
Kim, could you make me a cup of coffee?
We have one just trying to come on, and then. All right, well, I think we will get started. We got lots of people with us today. Welcome, everyone, to our Antimicrobial Stewardship series with Dr. Westley. We are very excited that everyone's able to join us today, and we're super excited Dr. Westley has agreed to do this with us. So without further ado, I'm just going to hand over the microphone to Dr. Westley.
Okay, great. Can you confirm again? You can hear me okay?
We hear you great.
Okay, excellent. Well, we did a series of this many years, 6 years ago, doesn't seem that long ago, but a webinar series that we had done in the past on stewardship. And it certainly is more than past time to update that and to give people new refreshers, new people into specialty, et cetera. So today's will be basically an introduction to that, some background, and then we'll get into some more specific topics as we go. At the end, in the past, we had a small group and a bit of a roundtable, which might be hard depending on the number of people. So I'll need some help at the end, possibly just reading questions from the chat, or if we end up trying to open up to questions, we'll try to leave a little time for that. So let's get started. Okay, so here's an accreditation and CME statement. So what we're going to try to do today is review components of effective antimicrobial stewardship programs, define what prospective audit and feedback is, which is really a heart of our inpatient programs that are affiliated with Providence and Alaska Native Medical Center, which I help with. Then we'll discuss methods of passing this feedback to the teams and how we do that. And then we will consider talking about penicillin allergies, delabeling assessments, and that's really a core intervention to programs if we can do that. So what are some key points? I think many infectious disease specialists, and certainly myself, love our specialty because it's really just very linear and logical. And it turns out that there's a pretty basic package of information that will cover 90 or 95% of the work that these programs need to do. It's actually really algorithmic and evidence-based and logical. There's nothing magical about it. And so we want to try to summarize that evidence and what we do in this series. Support from a pharmacy champion and a physician champion are really critical to helping disseminate this and making any interventions and recommendations acceptable. And then delabeling false penicillin allergies shortens length of stay and overall cost. So we are going to talk about that today. There are many standards now in place from CMS, different than 6 years ago when it was evolving. So I've just put them all here. And all programs really are needing to attest that these are in place for CMS credentialing, and the Joint Commission has very similar standards. Some of these are easier to meet than others. Trying to find a qualified individual that can be defined in various ways. One of the ones that we're working hard now is this bottom right one, which is a program leaders responsible for competence-based training and education on AMS guidelines, policies, and procedures. But basically, the program is supposed to document evidence-based use of antibiotics in all departments and services. These are pretty lofty goals. And I think that the accreditors know that this is challenging, but we're all sort of working towards this. So major basic components of antimicrobial stewardship can include the following, and these are not necessarily limited to inpatient or outpatient. You can pre-authorize certain medications with having requirements or actually asking for permission prior to being able to use something. We can formulary restrict stuff and basically mean we don't have access to it. Order sets will help trigger people to use the right antibiotics. In place, we also can have policies for automatic changing a medicine. If, for example, the organization prefers levofloxacin for cost or other reasons, maybe there could be automatic changes. There can be intravenous to oral route changing. One of the most important is the top right timeout at 48 hours we'll talk about to reevaluate everything and see if antibiotics are still required. So there are many different components that can be incorporated into programs, and these can vary depending on the size of the facility and the expertise available. In our programs, we still continue to think that prospective audit and feedback is the most valuable and sort of the heart of the program activities. Even though we have many guidelines and winning policies and procedures, there's nothing that really substitutes for reviewing individual cases, making sure the treatment's right or could be optimized, and then directly communicating those to the providers, on the ground. So today we're going to talk about prospective audit and feedback. Module 2 next week. The dates are not every week, but they've been sent to you all. So the second module will be respiratory tract infections. Third module will be skin and soft tissue infections. Fourth module, we'll talk about stewardship and urinary tract infections. The fifth module, we will talk about some intra-abdominal, sometimes surgical infections. The sixth module, we will discuss fever, sepsis, neutropenia, osteoarticular infections, IV drug user infections. And the last module will be a new one, and we will update on Clostridium difficile colitis, agents, management, prevention. That has evolved actually quite a bit over the last 5-6 years. Okay, so let's get into today's module. So first thing we need to talk about is how do we gather data and what necessary information is required to optimize antibiotics? How do we collect it? How do we actually do this work? The next thing we'll talk about is briefly looking at beta-lactam allergy assessment. This has historically been overlooked, but has massive impact on antibiotic use. And in fact, if you unnecessarily eliminate beta-lactams from your treatment option, there's an excess cost of care, length of stay, and even poorer outcomes for patients. Sorry, I need to move this. You can probably see my banner is in the way.
Nope, it's not in the way for us.
Okay. On mine, my video of everybody is in the way. So let me just go back to, hold on a second. Now I've got Zoom on top of my, maybe I can just do that. Hold on one second. Okay. Can you still see me and hear me?
Yes.
Great.
I've hidden entirely the Zoom bar. So if you disappear, I won't really know. But I'm here. Okay, now I can actually see my slides. So the last thing will be, how do we communicate these recommendations? So we'll talk a little bit about that. Do we leave notes, et cetera, right? So, and then how do we keep track of what we're actually doing? Intervention logging, data collection, what do we do with that stuff? So there are really two critical moments when antibiotics are being utilized in our program assesses what's going on. So the first is right when the antibiotics are being started. So why are they being started? What's the indication for that? Is what's being started the best thing based on what is presumed to be going on? If there's a urinary tract infection and there's an order for doxycycline or clindamycin, that would not be optimal because those drugs should not be used for urinary tract infections, as an example. And then you'd want to make sure our culture is actually being requested. It's not uncommon that somebody is started on antibiotics for a urinary tract infection, but nobody bothers to send a urinary culture, and you cannot diagnose a urinary tract infection without a urinary culture. So these are common examples. The next critical time is about 48 hours after initiating the antibiotics, and this actually can be a formal timeout when it's frequently referred to as such. It's an important time because it takes, in our modern day age where we use the same science as Robert Koch in 1882 to discover tuberculosis, we still grow bacteria on petri dishes. And so it takes time. So around 48 hours when we're getting these culture results back, this is the opportunity to figure out, is the patient getting better? Are the cultures back? Are the antibiotics correct? Or were the ones that we assumed were correct are no longer needed or need to be changed? So really the holy grail of antimicrobial stewardship, if it could be obtained, would be to administer the fewest antibiotics for the shortest duration that's necessary to optimize outcome. And you'd use the narrowest spectrum, least toxic regimen in the most cost-effective way possible. That's what we're all striving for. It's challenging, but I think all these programs have made a lot of progress over the years. So there's some really basic principles to live by in the stewardship world. And that's, first of all, if one medicine is okay, don't use two of them. There's only a few indications for combination therapy. We'll try to talk about at least some of those in this series. If two different regimens of medicine are equally effective, use the one that's more cost effective, use the cheaper one, or use the one that's less toxic. And typically, actually, the less toxic one tends to be the cheaper one. Don't treat something for 10 or 14 days if 3 or 5 are enough. There's no reason to treat something longer. This does not result in less resistance. It does not result in improved outcomes. And except for several notable exceptions, we should give things orally. If there's no mouth or no anus, it's hard for medicine to go in and out. But as long as there's a GI tract that's functional, most of the time oral antibiotics are preferred. So this is a nice description of that, published a few years ago by Brad Spellberg and Noah Walddickler. So Brad is really one of the stewardship gurus in the world, and just a common sense infectious disease physician from Southern California. And they recognize or make the point that Constantine units, so Emperor Constantine, ancient Roman times, when a calendar was being determined to have 7 days, somehow because of Constantine, we have ended up with treatment durations that tend to be 7 days or 14 days or 21 days long. And they summarize the literature in massive tables in this nice study. And they point out that community-acquired pneumonia, there's plenty of data that 3 or 5 days is equal to 7 or 10. For gram-negative raw bacteremia, 7 is equal to 14. For soft tissue infections, 5 days is equal to 10 days. And we show that here. He summarizes this literature, and we'll go through some of this in the next 2 months with the webinar series. But the main point is there has been a long-term overtreatment of most bacterial infections that clearly, based on evolving data, don't need as much treatment as we've been giving them, and that the treatment durations evolve from Constantine himself. Okay, so programs need to have metrics to figure out what we're doing and measuring our success and how we're making progress on things. This could be measured in multiple ways. So we can just follow how many broad antibiotics like 3rd and 4th generation cephalosporins, piptazo, et cetera, we're using. You can target certain classes. We'd really like to avoid clindamycin in the hospital, fluoroquinolones in the hospital. We can measure, and we should measure and track downstream markers of harm, such as Clostridioides difficile colitis and renal injury from antibiotics, vancomycin and others. We need to be monitoring our resistance patterns. If we do this right, the bacteria should actually not become more and more resistant over time if we can achieve that. So this is historical data I've shown in the past, but this is still one of the better slides to show when programs at hospitals that have been in place for a long time suddenly are created. So in 2013, stewardship program at one of my hospitals started, and you can see a substantial decrease in fluoroquinolone use, starting pretty coincident with the program. Same thing with overall antimicrobial use, and this has generally persisted over time. At some point, you get to a nadir and you can't use 0 antibiotics, but you should continue to trend this and make sure that the program is still operating at a high level. The other thing that can be done, which we find compelling, is benchmarking facilities. So in the whole system of multiple facilities, if you're in a system, facility-wide days of therapy per 1,000 days present, and all the facilities benchmark each other. And it's when you go to meetings or have phone calls on Zoom, you can egg each other a little bit about who's moving up or down in this chain. In this case, this is like golf, so lower thought to be better. Okay, so how do we figure out who we want to review and then talk to the physicians and optimize treatment? There's different ways to trigger that review. At our hospital, some of our hospitals, there could be 70, 80, 90 patients on a list to review. you do need to prioritize them or target them in some way. You can look for broad antimicrobials or double coverage that's not necessary. Certain disease states like staphylococcal bacteremia is dangerous and needs to be treated a certain way. That could be a trigger. Duration of therapy, you could have the computer trigger you if there's a certain amount of antibiotics that have been given for a certain duration of time. Or the system can even trigger you if something can be switched orally from IV, for example. So there's many ways to target this, and this will be different, again, based on the size of the facility and resources available. Once you want to review a patient, we really need to know who they are, how old are they, why are they in a hospital, and what's going on. Many times we'll be reviewing a patient and I'm asked about what antibiotics for a urine culture that has come back. And then I may ask, why is the patient in the hospital? And they're here because they stubbed their toe or they broke their ankle, and it has nothing to do with the urine culture results. So we need to know what is the situation of why we're even dealing with the issue at hand. And we do need to know what antibiotics they've been getting and what their allergies are. Then we need to know, when did they start on the current medicine? What's going on? Are they better, worse, etc.? And then we need to review what to do. So this can be accomplished by paper review. This can be accomplished by ancillary electronic health record extenders like Theradoc, or things can be built into EHRs such as Epic. At Providence, the entire system of hospitals has built a stewardship tool that basically knows what antibiotics the patients are on, what their allergies are, what the indications are, and then they can actually AMS score them along the fifth column you can see. And if the patient's on more or expensive or harmful or incorrect antibiotics, the AMS score can help you prioritize which patients you want to review first, which are more urgent to review, as an example. And then the pharmacist can leave notes for each other. So this is too much data for a doctor, but pharmacists love this stuff. Okay. Now let's just talk a little bit about allergies, because I'm sure all of you have seen a situation where a certain drug would be optimal, but the patient's chart says penicillin allergy, and we just don't know what that means. So 9% of patients have an quote unquote allergy to penicillin on their chart, but 90% can tolerate penicillin and are incorrectly labeled allergic. Also, nausea, headache, etc., loose stools are not allergies and don't preclude use of a drug. So recent studies have shown, this one was from 2019, a 6% mortality, or 6-year mortality 14% higher in patients that are labeled a penicillin allergy. Now, whether they have the allergy or not, if it's on the chart, they have a 6-year higher mortality of 14%. Patients that self-report a penicillin allergy have an increased cost of their antimicrobials that they end up receiving, because they end up getting medicines that are more expensive and potentially more toxic and not as effective. And then the medical record, unfortunately, this is getting better, but unfortunately, historically, has rarely documented the reaction. What is the reaction? What's going on? So we need to ask the patient and document that. We now know from extensive work and clinical following of patients over time that type 1 reactions, cross-reactivity varies, it's not linked really to the beta-lactam ring at the core. It's linked to the side chains of the molecules. So patients with a penicillin allergy, top row or left column, will have a side chain that is similar or somewhat similar to ampicillin, cephalexin, cefaclor, for example, but not all side chains are the same. And in fact, if you look at cefazolin, 8th row down and 8th column over, you'll see that cefazolin does not share a side chain with any penicillin or other cephalosporin. So this cross-reactivity chart can be extremely helpful for figuring out if a patient labeled penicillin allergic, for example, what is safe to give them or not. And I'm going to show you how this has been used recently. So because of this information, there have been several papers over the last few years getting pretty excited about how to deal with this. So a big one from California, a huge health system, went ahead and removed a cross-labeling of cephalosporin allergy in patients with penicillin allergy based on that cross-reactivity table. This was a 4.2 million patient system in California. They looked at 10 million antibiotic courses. And what they went and did was halfway through that data that they looked at, they removed the cross alert from penicillin to cephalosporins. And they had a comparison site that removed it and then another site that did not. So the intervention site removed the labeling, but the comparison site kept it the same. And so after they did that, cephalosporin use increased from 17 to 27% in penicillin allergic patients, which is what they wanted, to safely use cephalosporins in patients labeled penicillin allergic. But it did not change at the comparison site where they didn't remove the label. And there was no difference in any allergic reaction rates between the sites. Here they showed that there was a 1.7 odds ratio increased of using cephalosporins at those sites, and they used less vancomycin, less quinolones, less sulfa drugs, less clindamycin at the site that delabeled the cross-reactivity. Another study of pharmacy residents actually did something slightly different, but suppressed some of the alerts in the electronic health record to do the same thing. But what they did is they removed the alerts for non-high severity allergies. So basically, people that had anaphylaxis or immediate urticaria, they still allowed the penicillin alert to trigger for all beta-lactams. But for patients with a delayed onset drug rash, for example, the alert would not fire. And they showed a 91% increase in penicillin allergic patients receiving cephalosporins, decreased fluoroquinolone and aminoglycoside use. And in 204 patients post-intervention, there was no documented allergic reaction by doing this. So here was their flow. They basically said, if you have anaphylaxis, hives, or shortness of breath, the alert will fire. But on the right side, if you don't, then they suppress the cross-allergy alert. Unless it was penicillin. So if you have a penicillin allergy and then you try to prescribe penicillin, yes, the alert would fire. But if you have a penicillin allergy and you try to prescribe cefazolin or ceftriaxone, the alert would not fire. And they showed here in these tables that the non-beta lactams, the blue square, went down after they changed this. So more people were getting beta lactams and less people were getting alternative drugs. And then in the bottom on the bars, they actually show you how much reduced quinolone and aztreonam and aminoglycosides were being used after they changed the alerting. So here's what Nebraska does. Nebraska is very aggressive about this issue. And if somebody has an intolerance, just like I mentioned, nausea, diarrhea, we discuss with the patient and we give the full dose beta lactam. We do the same thing or try to if we can catch it, but Nebraska routinely does that. If there's a mild or unknown reaction, they say that you can use any cephalosporin or carbapenem, or you can delabel the allergy, which we'll talk about in a minute. Then there are more complex pathways here. This is more aggressive than what we've done at our hospitals yet. I'm not sure if I'm brave enough, but I should be. Patients that have a type 1 reaction, including anaphylaxis, and the reaction occurred greater than 10 years ago, they will use cefazolin or a carbapenem or a third or fourth generation cephalosporin or something else. That's sort of the middle large box. But even patients with a type 1 reaction within 10 years, they still allow use of cefazolin or carbapenems because there's no side chain cross reactivity. And then on we should mention type 2 to 4, the top right upper corner, there are rare cases that patients will get Stevens-Johnson syndrome, skin sloughing, other extremely dangerous side effects of antibiotics, which in this case, they recommend avoiding all beta lactams. But even for type 1 reactions, it may be possible to use cefazolin or carbapenem. So this is what Nebraska is doing. They have an excellent website that you can check out. And then on the left side, previously tolerated beta-lactams. You can use what they previously tolerated, of course. And if you're using a different agent, they still point out it's safe to use cefazolin or carbapenem. Now, if you want to unlabel this, if you want to remove a labeling from somebody who thinks they may have had a bad reaction to amoxicillin, but they just don't know, one thing that can be done safely in the hospital is to challenge. So the way Nebraska does it is they give a 25 and then a 250 milligram dose of amoxicillin half an hour apart. And if there's no reaction, they remove the penicillin allergy and they administer the full dose of beta-lactam. I have frequently given 250 milligrams of amoxicillin once and waited 2 hours and then delabeled the allergy and used what I want to use. So there's different ways to approach this. This is what Nebraska does. The patients need to be inpatient or emergency department, so they're observed carefully. Their epinephrine needs to be available if they do have a reaction, and they cannot be pretreated with antihistamines because that could blunt the response. And then you need to check the vital signs and symptom checks, typically every 30 minutes. Okay, so that's some penicillin allergy stuff we can come back to later if there are questions. So once we have assessed these things and we have a recommendation on antibiotic management, what do we do? So the first thing is that doctors are really busy and they think they know everything. And I know what I'm talking about because I'm a doctor. I know for sure what I'm talking about. So the crazy thing is that some doctors hate being paged, but some like pagers. Some like text messages. Some hate being text messaged. Some want a note in a chart. Some just want you to entirely leave them alone and never talk to them, which is not an option. But everybody's different, and it's helpful to know what that is. So at our hospital, it kind of depends. Historically, Ryan Stevens, when he started this program, kept a whole spreadsheet of how people wanted to be contacted. And he found out that different people had different opinions, and it made a difference. People were more likely to accept what you're telling them if you contact them the way they want to be contacted. Now we have these protected text messages within the EMR. And that seems to be one of the best ways to chat with people in our system. But it made a difference. And in fact, after he left, Ryan wrote this up and he called it Method to Madness, Impact of Method of Contact on Our Acceptance Rates. And he basically showed that no matter what the intervention was recommended, stopping, changing, escalating therapy, everything was more likely to be accepted, 15 or 20% more typically, if you called somebody on the phone rather than just leaving them a note. And then we also looked at it by individual providers. These were the top 13, and all of them trended towards better response if you were talking to them on the phone. So we recommend talking to people and telling them what we're doing. I'm the antibiotic stewardship pharmacist. If it's a locums person, they might not even really know what that is. So you tell them what you're doing, what's going on, why we're trying to help. And then, is it okay? How do you want me to call you in the future? Text, call, leave me alone. It's good to know that at the very least. And then if you're at a small hospital or even our hospital, sometimes it's easier just to go find somebody. If they're in the ICU, just wander over there. Or if you know where they are at a charting room, we call this handshake stewardship, and many papers have reported basically the same thing that Ryan did with the phone, which is that in-person stewardship improves acceptance. So we want to verify and say, hey, like, we reviewed this case. Is our impression the same as what your impression is? And then here's what we think. This patient has pneumococcus, and the literature is very clear that 5 days of community-acquired pneumonia treatment is adequate. And that we can use amoxicillin or ampicillin or whatever we would want to recommend. And then if there's questions or concerns that can't be answered there should always be a physician champion supporting those recommendations that can talk to the provider about why we do that. Having pathways are great because then you can just refer to your website or your pathway and say, hey, here's what we do for pneumonia. Here's the pathway. Here's why we're saying this. Now, not everything's going to be accepted. There are just going to be times where the physician's concerned and can't articulate what the exact worry is, but they're not comfortable with the recommendation, and that's okay. But it should be documented that way. Okay. So most EMRs include some type of mechanism for recording pharmacy interventions, some systems called iVent or others internally so that everybody can keep track of this. Some systems will even calculate cost avoidance and other issues within the system. So we typically do that. If you don't have something like that, you can build a Excel spreadsheet and it can be quite powerful. We've published several studies out of our Excel spreadsheets in the past. But it's really critical to log each intervention because you can't really trend and track your activities and know what's going on and to know whether they're accepted or not. So we record them in the EMR, but a backend iVent system, it's not typically in the progress notes. But if the providers want us to put a note in, we can. And sometimes we will put a note in, especially if culture results have come from a different hospital and there's information that needs to be articulated. We will put a note in, but we don't put a progress note for every single intervention, as some providers find that a little bit unpleasant and aggressive. And there's no defined best practice still on that, to my knowledge. So we're only about 30 minutes, and I went through a bit quickly, but this is just sort of our initial background webinar. So I think what we could do is open things up a little bit, and basically for general program practice, procedure, et cetera, just kind of hear a little bit about what program components are challenging for everybody, what things they might want to hear through the remainder of the webinar that I could try to incorporate. Do the facilities or people involved in their programs have tools they need, or what is missing and would be most helpful throughout our system? Any specific training assistance that facilities would like to be provided in the future, and then other questions. So I think what I can probably just do is stop sharing. Yeah, now I can see the meeting. And if I need to, I can go back, or we can pull slides up. So I probably just need one of the moderators, if they can help either read something from the chat or open people up if people want to ask questions.
Absolutely. People want to just unmute and ask a question, or put it in the chat, or raise your hand, and we'll get to you.
It's pretty good. It's almost 70 people. It's great.
Looks like we do have a question in the chat. Does your facility charge for penicillin allergy delabeling?
No, we don't do penicillin skin testing. Virtually all these people can be delabeled without skin testing. And if somebody clearly has a penicillin allergy, type 1 penicillin allergy, and it's documented, and they need penicillin, they're pregnant and they need penicillin for syphilis, for example, then they would need to be desensitized in the hospital. The only other alternative for us right now is if they needed penicillin sometime in the near future, but not urgently, we could send them to allergists as an outpatient to have skin testing done. But we don't really have a process in the hospital to do it routinely. At ANMC, we do occasionally do it inpatient. At Providence, we don't have anything formally set up. But many hospitals have, especially with now pharmacy practice, built a program that is run in that manner, and then those services should be billable, but we have not implemented that.
It looks like there's another question here. How do you document your penicillin delabeling? Does your program remove the allergy and notify outside healthcare providers?
We educate the patient, and then we remove it from our system. But that's a problem. That's a big problem because in the private sector, almost everybody's on different systems between their primary doctors or their rural clinics. In Anchorage at ANMC, there's a single system. However, the regions do not all use the same integrated Cerner system. Many do now, but not all. So that is a limitation. I feel like we should be giving patients a card, almost like when you get a pacemaker and it has the information on your pacemaker on it. But we haven't been doing that. And this is mostly probably been a one-off when providers involved are comfortable doing this. And unfortunately, this isn't something that we don't have a protocol in place for pharmacy review of the allergy and sort of automated test dosing and delabeling directly from a stewardship pharmacy office point of view. We really have the clinicians instituting this at our recommendation. So if desensitized and documented chart as such, hopefully past record review wouldn't lead someone to believe not allergic. Yeah, we don't remove the allergy from people that we desensitize because they're still allergic. So as soon as you desensitize somebody to penicillin, you can treat them, but as soon as you stop their treatment, they will be allergic again. So we don't delabel those people.
Any other questions?
Hey, this is Anna from the state. One thing we've been doing with the state sort of infection control group is we've been visiting lots of different hospitals and like talking with them about their stewardship programs. And the thing that I see people, we have to go through CDC's core elements of stewardship. And the element that people are missing the most often is the one where you have to track like the success of your, like, do people adhere to the recommendations that you make, sort of evaluate your program kind of metrics. So could you talk a little bit more about that? That's the mistake I see the most.
Well, it's almost virtually impossible. It's extraordinarily hard to figure that out because, you can, the simple way to do it, but it may not provide very reliable, high quality information because indications for antibiotic orders are required at accredited campuses. So the easiest thing to do is to just track and trend, are the antibiotics for some indication that you're interested in correct? So you could just pick community-acquired pneumonia, or you could pick acute sinusitis or something for outpatients. And then you would say, hey, people shouldn't be getting Bactrim for that, or Macrobid for sinusitis. And you could track and trend and give feedback to providers. Hey, the antibiotics you used for an indication of XYZ aren't correct. What most of them have told us in the past is that they don't put the correct indication on the box because it's a pain, so they just click whatever. Well, then the complaint is that the data is not reliable. But I think if you bug people enough and just say, hey, we're going to keep annoying the heck out of you because you're clicking something that isn't correct, maybe you should start clicking the correct indication for your antibiotics. So I think it's a feedback loop that could hopefully be a positive, not a negative feedback loop. So that's one way to do it. The other way to do it is actually just to audit. You'd have to audit a subset of charts on a regular basis to try to figure out what's going on. But when the criteria says monitors evidence-based use of all antibiotics across all departments, that's a pretty heavy lift. So I think that facilities can show how they're trying to follow antibiotics and know where the antibiotics are prescribed and in what units and what the tracking and trending of that is. That's a way to start. I don't think our process is as robust as we would like it either, but in all of our surveys, it hasn't become a bigger issue yet. I don't know how it's going to evolve. I don't know if Katie or Shauna is on this call because
they are, I think.
I don't know if Katie or Shauna wants to try to help answer that question because they do so much of the nuts and bolts of our data monitoring. But we have definitely struggled with that issue a bit.
So this is Shauna. The one really the only way I can track it is if I review it to make a recommendation. Our intervention process allows us to put accepted, rejected, and then the provider's name. So I can go back and run reports and see which providers have rejected certain recommendations. But unfortunately, it is hard for me to audit certain indications and like compliance with community-acquired pneumonia order sets. Because again, while those indications are on the order, it just depends on whether or not they pick the correct one.
Yeah, so this is Katie. I put it in the chat, but we did this for, well, I should say I did it for, I think I picked a month, but it was as I was going through the patients doing their prospective audit and feedback. So it wasn't a change from usual practice. So if they weren't following, we made the intervention and they were following. So it's not actually that helpful, but it checks the box for CMS and Joint Commission to say, yeah, we audited it because it's what we do every day.
Did we do urine, or I can't remember what you did?
We've done H. pylori, CAP, and then urine. We looked at cultures and if they had an indication to culture. And then I've had students do like short bursts of patients. So they've done UTIs in our walk-in clinic and STIs in our walk-in clinic.
Yeah.
And I also have a report that looks at the indication that they selected on the order and which antibiotic they picked. And so I can somewhat do an audit by going and looking at all that they picked community-acquired pneumonia as indication and what drug were they using to assess if they were picking the empiric drug that's on our guideline. Unfortunately, once you de-escalate, you kind of lose that because we use ceftriaxone empirically for UTI, and then we'll de-escalate to whatever when sensitivities are back. So it's still, there's still a big gap in that data.
Yeah, and I would say our stewardship program at Providence is very now pretty intimately related with a whole system antimicrobial stewardship initiatives, and things are kind of beginning to align throughout the system for better or worse, but there really isn't a system-based tool to do what you're talking about, Anna, even though everybody is supposed to be doing it.
Any other questions or comments? Kristen just put in a note about the AMS Summit on February 14th, the link there to register. And we do have some travel support for rural hospitals, pharmacists. So please let us know if you have any questions. You can reach out to Kristen or to me. And Dr. Westley will be there speaking, and Ryan Stevens, is that his last name? And a few other great speakers here from Alaska.
Yeah, looking forward to it. That's my idea of a Valentine's Day. So.
Well, our next session is February 5th, like I think Dr. Westley mentioned, and each one has CEs. I put information on how to get your CEs. If you have any problem, reach out to Kristen or to me if you can't get into that system to receive your CEs. So, any last comments?
Okay, really appreciate everybody. We'll talk soon.
Thanks, everyone. See you in a few weeks.
Okay, bye.
Bye.